GnRH analogs and antagonists used in ART cycles. Gonadotropin releasing hormone, GnRH analogs and antagonists play a critical role in assisted reproductive technology, ART cycles, including in vitro fertilization, IVF, and intrauterine insemination, IUI. These agents are used to manage and control ovarian stimulation, prevent premature ovulation, and optimize the success of ART treatments. There are two primary categories of GnRH-based medications: GnRH agonists, GnRH antagonists. Both types help manipulate the hypothalamic-pituitary gonadal axis to control the timing of ovulation, which is essential for egg retrieval in IVF and optimal timing for insemination in IUI. 1. GnRH agonists. GnRH agonists are synthetic analogs of the naturally occurring GnRH, which is produced by the hypothalamus and regulates the release of luteinizing hormone, LH, and follicle stimulating hormone, FSH, from the pituitary gland. Mechanism of action: GnRH agonists initially stimulate the pituitary gland to release LH and FSH, resulting in a temporary increase in these hormones known as the flare effect. However, with continuous administration, downregulation of the pituitary occurs, leading to a decrease in LH and FSH secretion. This suppresses ovulation and prevents premature luteinization, premature ovulation. This controlled suppression is important in RT cycles, as it allows for the precise timing of ovulation once gonadotropins, FSH, and HMG are administered to stimulate follicular growth. Indications: prevent premature ovulation in IVF cycles to ensure proper timing for egg retrieval. Pituitary downregulation in IVF cycles to control ovarian response. Ovarian stimulation and endometrial preparation in women undergoing ART. Forms of GnRH agonists: Leuprolide, Lupron, a widely used GnRH agonist, available in both daily injections and long-acting depot forms, e.g. Lupron Depot. Goserelin, Zoladex, another GnRH agonist used in RT cycles, available in implant form. Triptorelin dicapeptyl, also used in ART cycles, available as a long-acting injection. Types of GnRH agonist protocols: long agonist protocol. Pituitary downregulation is achieved with GnRH agonist given for 2 to 3 weeks before ovarian stimulation begins. Once downregulation is confirmed, low LH and FSH levels, gonadotropins are administered to stimulate the ovaries. Advantage: this protocol provides a stronger control over ovarian function and ovulation timing. Disadvantage: it requires a longer duration of treatment and increased monitoring for ovarian response. Antagonist protocol, modified long protocol. GnRH agonists are given during the early follicular phase for pituitary downregulation, followed by the addition of gonadotropins. This is commonly used in high responders to prevent premature ovulation. 2. GnRH antagonists. GnRH antagonists are synthetic drugs designed to block the action of GnRH at the pituitary level, preventing the release of LH and FSH. Unlike GnRH agonists, antagonists do not cause the initial surge in LH and FSH, but directly suppress their secretion. Mechanism of action: GnRH antagonists bind to the GnRH receptors in the pituitary gland preventing GnRH from stimulating LH and FSH release. This immediate suppression prevents premature LH surges, which could lead to premature ovulation, thus making them ideal for use during ovarian stimulation in ART cycles. Indications: prevent premature ovulation during ovarian stimulation in ART cycles, e.g. IVF and IUI. Shorter downregulation phase compared to GnRH agonists, used in poor responders who need shorter and more controlled cycles. Advantages of GnRH antagonists: rapid onset of action. They immediately suppress LH secretion and prevent premature ovulation without the initial flare-up seen with agonists. Shorter treatment duration. Treatment duration is typically 5 to 10 days, making it more convenient and less time-consuming than the long GnRH agonist protocol. Lower risk of ovarian hyperstimulation syndrome, OHSS. Due to the shorter treatment and immediate LH suppression, antagonists can reduce the risk of OHS. Forms of GnRH antagonist: cetrorelix, tetrotide, a commonly used antagonist available as daily injections. Ganirelix, orgalutran, another widely used antagonist for preventing premature ovulation, available as subcutaneous injections. Elagolix, Orilissa, a newer GnRH antagonist, mostly used in the treatment of endometriosis, but occasionally used in ART cycles. GnRH antagonist protocol. GnRH antagonists are introduced during the early phase of ovarian stimulation, usually on day 5 or 6 of stimulation, once the follicles have started to grow. Gonadotropins, FSH or HMG, are administered to stimulate follicular growth, and the antagonist is continued until ovulation trigger. 3. Comparison between GnRH agonists and antagonists. Feature: GnRH agonists. GnRH antagonist. Mechanism of action: suppress pituitary function via downregulation, flare effect followed by suppression. Suppress pituitary function by blocking GnRH receptors. Treatment duration: longer, 2 to 3 weeks before ovarian stimulation. Shorter, 5 to 10 days during ovarian stimulation. Timing of administration: early in the cycle for pituitary downregulation. After starting ovarian stimulation, day 5 to 6, using ART, primarily in long agonist protocol for more controlled ovarian stimulation. Used in antagonist protocol, preferred in normal and high responders. Advantages: stronger control of ovarian function, rapid onset, shorter treatment duration, and lower OHSS risk. Disadvantages: requires a longer time for downregulation and higher risk of OHSS, can be less effective in poor responders. 4. Clinical considerations. A. When to use. G. NR. H agonists versus antagonists in ART. GnRH agonists. Best suited for patients with high ovarian reserve who need a more controlled ovarian stimulation cycle. Preferred for those with polycystic ovary syndrome, PCOS, or those undergoing egg freezing where more precise control is needed. GnRH antagonists, best for normal responders, poor responders, and those with high estrogen levels. Ideal for patients who require a shorter stimulation phase, offering convenience and less risk of OHSS. B. Side effects and considerations. GnRH agonists, hot flashes, headaches, mood swings, and bone density loss with long-term use. Can cause ovarian cyst formation due to initial flare. GnRH antagonists, injection site reactions, e.g., redness or swelling. Ovarian cyst formation is less common than with GnRH agonists. Headaches and nausea can occur in some patients. Conclusion: both GnRH agonists and GnRH antagonists play a significant role in controlling ovarian stimulation in ART cycles. The choice between the two depends on factors such as the patient's response to stimulation, the risk of ovarian hyperstimulation syndrome, OHSS, and the desired duration of treatment. Both have specific advantages, and the right choice will depend on the patient's condition and ART protocol.